Good
What is
morning,
the
or
time?
rather good night. So
Both.
nice of you to wake up early.
Yeah, being a Sunday, it's easier, no?
Yeah, so
So in this video sessions, are the participants already there?
Yes, yes.
Okay, fine.
Other-
There are 32 participants.
Okay.
Good morning, good morning.
Good morning,
Manju, I
madam.
think we
Morning,
should
Tanya.
start right time. Good morning, madam.
Good
Yes.
morning, this is Chechen from Delhi.
morning.
Hello, good morning.
Good morning, ma'am.
I'm
Jyotsna.
joining from mobile only, right?
Jyotsna, very good morning.
Good morning.
I think we should start, Manjusha.
Yeah.
Yes.
Yes.
Virender, can we start with the prayers?
Sure.
Is it running, madam?
We can't hear the.
Okay, don't worry, I'll just sing it. Don't worry. Yeah? Shall I?
Please,
Yes,
ma'am.
yes.
Yes, please.
Saraswati Vidhiyuvati Saraswati Vidhiyuvati Samrakshatu Mam Shri Saraswati Vidhiyuvati Murali Veena Gana Vinodini Samvedini Charuchandra Hasini Sarasiruha Lochani Murari Guru Guha Modini Shabdharta Swarupini Hamsini Brahmani Araktavarna Rupini Saraswati Vidhiyuvati.
Oh, that is wonderful. So, good morning, respected seniors and dear colleagues. A warm welcome to each and every one of you to this inaugural virtual conference of women in pediatric surgery. A momentous gathering that marks the beginning of a remarkable journey. Today, we unite not just in the virtual realm, but in the spirit of fellowship and shared passion for pediatric surgery. As we embark on this groundbreaking event, let us celebrate the trailblazing women who have devoted their careers to the delicate care of our young patients. This conference is a testament to their dedication, resilience, and the profound impact they have on shaping the future of pediatric surgery. In the spirit of unity, let us seize this opportunity to engage, ask questions, and share insights that will contribute to the collective growth of our community, our group, us. I would like to take this opportunity to thank IAPS President Dr. Ramesh Babu and Secretary Dr. Vikesh Agrawal for their vision for this conference and constant encouragement. I extend my deepest gratitude to each participant, chairperson, speaker, moderators, and organizing committee members, and the audience for contributing to this momentous occasion. May this virtual conference be a source of inspiration, collaboration, and empowerment as we collectively shape the canvas of pediatric surgery. Thank you and enjoy the conference.
Thank you for those wonderful words, Dr. Manjusha. May I now call upon Dr. Ramesh Babu, President, Indian Association of Pediatric Surgeons, to please say a few words.
Very good morning, friends. It gives me great pleasure to inaugurate this special event of IAPS-WIPSCON ahead of International Women's Day. This special event for women's pediatric surgeon is a hand-holding gesture of IAPS to keep our association vibrant, search new talents, and develop women leadership further. I congratulate the women organizers for putting up such an event. IAPS has started a lot of new initiatives this year. Lateral thinking has led to many such innovative measures in IAPS, like next generation mock exams, then the upcoming WIPSCON, the social media prominence of IAPS, or our enthusiastic efforts to celebrate the Pediatric Surgery Day with extra vigor, backed by loads of awareness creatives and its dissemination in all realms of present era platforms. And I should say that many of these were done by our young girl pediatric surgeons who have just passed out. As I conveyed, women's event or upcoming WIPSCON are examples of efforts to nourish leadership in our association, as these events are designed and fully executed by these groups, IAPS being only the facilitator. Over the last few years, more girls have opted for pediatric surgery and have kept the IAPS flag flying high. They need to get motivated by surgeons who have reached great heights, by listening to the wisdom of people like Dr. Bharti Kulkarni, Jyotsna Kirtane, Snehalata Deshmukh, Shuramani Gopal, and many other names who I have missed. The newly joined girls can gather a lot of hope and confidence. There are a lot of hidden talents in our youngsters and women. It is high time we garner these talents and develop ourselves as a rounded personality rather than just focusing on academics. I hope we enjoy and learn over the next few hours. Long live IAPS. Thank you.
Thank you, Dr. Ramesh. Very encouraging words for all of us here. And we do have a very dynamic leadership at the IAPS currently. So may I invite the Honorary Secretary, Dr. Vikesh Agrawal, to say a few words as well.
Thank you, Virender. Respected IAPS President, Dr. Ramesh Babu, my teachers here, Professor Dr. Bharti Kulkarni, Professor Dr. Jyotsna Kirtane, my dear friend and executive members, Dr. Manjusha and Dr. Priya Ramchandran, who have taken the lead for this event, my dear friend Shilpa Sharma, for guiding throughout the journey of preparation. At the outset, I would like to congratulate all of you. Probably amongst men, I'm the only one who has been closest to the organizers. So I saw the journey, and it was so heartening to know that there's so much of camaraderie among women members here, and so much of enthusiasm with more than 250, 300 people registering. And people are like wanting for whole day event. So that in itself suggests that the level of enthusiasm towards WIPSCON reflects the need for a WIPSCON every year. There may be few differences of opinion, but what I intend to say here, the niyat is good. Niti the time will tell what is going to happen. So I congratulate all of you, wish you all the best. IAPS office currently is very innovative, sensitive also, and open to new ideas and suggestions. After this event is over, I will just request all the members, all the participants to give their feedback to me on my personal email ID or phone number. With this, I wish you all the best for today's event. Thank you very much.
Thank you, Dr. Vikesh. So Niyat, Niti, or Nari, that's a, I've added Nari to that, so that's a deadly combination, I guess, going forward. So thank you for those words. Dr. Manjusha, if you permit, can we begin with the program? We are 5 minutes early, but I guess that's a good start. You are muted, ma'am. Dr. Manjusha, you're muted. Kindly unmute yourself. Yeah.
We can wait till 5. We can wait 5 minutes more.
Sure, ma'am. Sure. All right. So we should.
So exactly at 9 o'clock we'll start, or maybe
Sure.
after 2 minutes.
Sure. So we shall.
A little more for to wait for everyone,
Sure.
because 4 people have already joined.
right? So if we have any more male members who are wanting to say anything, because once the conference starts, I think it will be more of female members who will dominate the stage. So I can see quite a few other members joining as well. So that's wonderful.
I'm going to make a cup of tea now.
If you can stop the screen sharing, I think we can take a group photograph. That's the best
Sure,
time
ma'am.
to take it.
Yeah, I'll do that,
Yes.
sure.
Everybody take, please, then we can share whatever screens one has got.
And we have to start the laptop. Oh,
There is a new group photo option also on Zoom. If we have it as host, you can do that. I can't do it from my screen here. So just try that.
Where
In
is
the
that?
apps, you have a group photo option. Vikesh, I think you can help us with that.
No, I just want to know. I've never used it.
So there are
Where
4
is that?
apps on the right side of Zoom. One is a timer, one is a group photo. So just look right on the right up screen. You'll have apps.
More option.
Because there's 6 screens. If let us take all the 6
So
screens then one by one.
actually, I am not the user right now. I think I'm just a participant. So Gayatri must be having that control there.
Gayatri, can
Or
you
is-
check, please? Because it says tell the host to do that.
Disha, if you are there, just check the option. Click on the apps and there are multiple options.
Yes, madam, we are doing that. We are doing that.
Yeah.
We can see here Professor Dr. Churamani Gopal Madam also. Madam, good morning.
Yeah.
Welcome.
Good morning, Dr. Vikesh. I'm very happy to learn you have become secretary. Congratulations.
Thank you, Madam. Thank you for joining us and encouraging us, Madam.
We can have a few words from Jyoti, Pam, and Kalpana.
yes.
Yes, please.
Did you say my name?
Yes.
Yes, ma'am.
Yes, madam. Yes, madam.
Yeah, okay. Good morning, everybody. I'm delighted to see so many girls. I call them still girls with my seniority in age. You're all girls.
You are also
Except me,
girl ma'am,
Saroj.
for us.
Saroj and I had a good time in London together at Great Ormond Street.
Nice to
What
see
should
you
I say?
after
This is
long
a
time.
fantastic initiative. Hi, Saroj.
Hi, so nice to see you after a long
Looking-
time.
I'm seeing you after a long time and you're looking very dignified, I must say. So I wish all the best. You know, I'm amazed to see the enthusiasm and the advances these youngsters are making. Everybody's into laparoscopy, into robotics, and it really gives me great pleasure to watch their videos. I'm not all the time on WhatsApp, but I do see it off and on, and I really appreciate what I watch and see and read. Doing complex cases and amazing confidence, yes. What I would like to say is maybe abroad in certain countries, there was some discrimination against the female sex. But as far as my experience goes, I never had that feeling. I mean, we were all treated as equal and we had a wonderful time together.
Kalpana, you
Is
want to say
Bharti around?
something? Kalpana, this entire idea was from your session. When I asked you to host a session on SPUCon several years ago, you brought a lot of female leaders from Europe and it was fully female event. I thought, why can't we have one in India? Because so many girls are joining this PG these days. You know, I mean, if you see the next generation mock exams we are conducting, all of them are girls, basically. So they are so enthusiastic and then they are so vocal. They are so communicative. I mean, we should, women always have better communication skills, you see. So Kalpana, you say a few words about this entire event?
Yeah. Thank you, Ramesh. I didn't know I could influence from so many thousand miles across, but it's good if it has had a positive impact. I think the sheer numbers speak volumes, isn't it? And I'm really very happy. Although I don't know each one of you all personally, I know a few. Of course, Jyotsna has been my teacher. And Meena Agarwal also, she's been one of my colleagues, or rather, she is one of my colleagues. And women in pediatric surgery, there is a forum here as well in UK, and they meet every year. And activities like this, more than anything, they bring everyone together. I consider that as the most important thing, because if you can communicate, you can take it further. And in the panel that I see, I was trying to take screenshots. There are so many youngsters. I feel old, but that doesn't matter. It's just very encouraging to see so many. And thank you for inviting me.
I think it's now time to move on to the meeting.
Yeah.
If that's all right.
Yes.
So,
Can we
yes,
start?
ma'am. Yeah. So we shall begin with the formal paper presentations now.
Yes.
The first is the free paper session 1, which shall be chaired by Dr. Lakshmi Sundararajan, Dr. Tikchin Lama, and Dr. Mamta Senger. May I request the chairpersons to please take it from here. I think the Zoom team shall be keeping timings, and each presentation is 5 + 1 minutes. And I think the chairpersons have already been informed that the papers need to be marked 5 points each for 5 criteria. One is finishing in time, the style of presentation, content, originality, and answer to questions, if any. So we'll have 1 minute for question answers. So may I invite the first speaker, Dr. Disha.
Good morning, ma'am.
Good morning. So with the permission of the chair, can we start the session, please?
Yes, please go ahead. Just to say, the chairpersons for this session are myself, Lakshmi Sundararajan, Dr. Tikchin Lama from Delhi, and we have got Dr. Mamta Senger from Jaipur. Please carry on.
Good morning, everyone. I'm Dr. Disha Shajil from Vadia Hospital for Children. Today, I'll be talking about implementing a disorders of sexual development, that is a DSD bundle, in patients with isolated proximal hypospadias, and if it is worth the stigma. So proximal hypospadias patients with associated morphologies are usually evaluated extensively, but patients who present with isolated proximal hypospadias are not evaluated so much. Also, with the association of a DSD, there is a stigma, which is the parent and child focused stigma, along with illness intrusiveness. When this stigma starts to invade into their daily activities, this leads to more depressive and anxious symptoms in the parents, and ultimately influences the adjustment that the child has in the society. So proximal hypospadias is only 20% of all hypospadias, but is a component of a more complex anomaly, that is the DSD. So there's always been a controversy regarding evaluation of such patients. So we've come up with a DSD diagnostic bundle to find out the incidence about hormonal markers which are present in such patients, and to see if it is worth the stigma of putting them through such tests. So a DSD evaluation bundle is necessary because it is useful for gonadal management, predicting fertility potential, sexuality, genetic counseling, and long-term outcomes. Analysis of a DSD pathway, what we did was in patients of isolated proximal hypospadias, we divided them into a known DSD subtype or not fitting into any known subtype based on certain hormonal workup. After that, a 46XY patient, went through workup based on the testosterone level. If the testosterone was high or normal, which was increased with some basal LH or FSH, it was categorized as a partial androgen insensitivity syndrome. If they had testosterone and dihydrotestosterone greater than 70, then it was a 5-alpha reductase deficiency. If testosterone was low, then we gave an HCG stimulation test, and then if the testosterone came high, it was a synthesis defect. But if there was no response, then it was gonadal dysgenesis. Based on mosaic pattern, if it was associated with 46X chromosome, then it was an overtesticular DSD. If it was 46XX, then it was a mixed gonadal dysgenesis. If after all this workup, the patient wasn't fitting into any subtype, then we put them through certain chromosomal testing and genetic evaluation, etc. After that, they were categorized into a known subtype, or if not, then they were defined to not have DSD at all. So we found out of 60 patients, 9 of them had abnormal DSD markers, 3 having androgen biosynthesis defect, 3 having hypogonadism, 2 having 5-alpha reductase deficiency, and 1 having partial androgen insensitivity syndrome. So there aren't sufficient literature around for categorizing the DSD incidence in patients with proximal hypospadias. But in our center, which is a center of excellence with a well-established DSD clinic and a comprehensive group of endocrinologists, genetists, and pediatric surgeons, we have got the incidence of such patients with 16%. That is 16% patients had DSD in isolated proximal hypospadias, which is quite a large number. So the reason, but the study was still limited because it was a single institution study and not all subjects had evaluation for DSD. Even the extent of investigations varied from patient to patient. The reason we need for an evaluation of DSD is because in patients of 5-alpha reductase deficiency, there is a risk of recurrence and have to be counseled accordingly. Virilization can, however, improve after puberty because the endogenous testosterone would rise. In patients with partial androgen insensitivity syndrome, the long-term outcomes can differ because of the higher rates of failure in hypospadia surgery and development of gynecomastia. Patients with 46X, 46XY mosaic, which is ovotesticular patients, the infertility is much higher than expected. And in bi-chromosome partial gonadal dysgenesis, there is increased risk of germ cell neoplasm. So because of all these reasons, it is very important for DSD to be picked up in such patients. However, standard investigation protocols in all hypospadias patients are still lacking. So should all proximal hypospadias patients undergo DSD workup? Yes, definitely, because there are multiple functional implications like we see, and the incidence is quite high. It cannot be neglected. And it is definitely more than what we have come across because patients are still undergoing the study. However, in this process, we have to protect all hypospadias patients from the mental stigma of DSD and be sensitive with this matter. Thank you for your time.
Thank you, Disha. Yes, Lakshmi ma'am.
Yeah, it's okay. Just we have very short time for questioning and she has exceeded the time. So there are 2 questions in this. One is, what are all the spectrum of proximal hypospadias? And what was the kind of hypospadias in the patients who had a DSD problem, right? That's number 1. And number 2, you have not looked at the penile size as an indicator where we are checking for DSD. So did the patients who have DSD problems, what was their penile length and, in comparison to normal?
In patients with proximal hypospadias, we have included pinoscrotal, perineal, and scrotal hypospadias. The stretch penile length in general is much lower as compared to in patients with DSD as compared to those without. And other criteria, morphological criteria like inogenital distance, the glans width, the urethral plate dimensions are also a little lesser than of those of normal.
Sorry, Ma, you are exceeding your time limit, so just keep your answer very brief. I asked you specific questions, so I think we can go on to the next. Okay?
Yes.
Sure, ma'am. The next presentation is by Dr. Anju Verma. Please share your screen, Anju. Anju is from the Department of Pediatric Surgery, SGPGI, Lucknow. Please make it a slideshow, Anju, and start.
Is it okay, ma'am? Not visible. I'm visible, ma'am?
Yeah, the slides are visible and you're audible. Kindly start.
Okay. Greetings from SGPGI. I'm Dr. Anju Verma, presenting our surgical technique, experience, and early outcome of robotic excision of choledochal cyst with true and white hepatocytosis in children. So, as we all know, the mainstay of treatment of choledochal cyst is complete excision of cyst along with the bilioenteric anastomosis. At our center, we used to do hepatocytosis. Traditionally, it is performed as open procedure, but after the 1995, when the first laparoscopic repair was done, it is usually now done as a laparoscopic repair, including at our center. But after 2006, the first report of robotic CTC repair has been published. Now it has been done as robotic also at the very center. So we aim to show the surgical technique, experience, and early outcome of robotic excision of choledochal cyst with Roux-en-Y hepatocytosis in children at our center. It was a retrospective review under the study duration of around 2 years, and all children who underwent robotic hepatocytosis were included. We excluded 3 children whom we have to do hepatocytosis due to some circumstances. For selection criteria, first main important thing was the availability of robotic operative room slot at the time of patient planning, availability of finances with the parents, surgeon preference, and parental request for the robotic procedure. There was no specific criteria with the regard of patient age or anatomy of choledochal cyst, and patient who was scheduled for surgery for at least have 6 weeks for the last week of cholangitis. The operative preparation was same in all the patients, including LFT, ultrasound, MRCP, for the proper delineation of biliary and pancreatic ductal anatomy. So this is the patient and port position. We use 8 mm robotic port along with the one assistant port. The distance between the two ports is between 6 to 8 centimeters, and the distance between the target and the camera port is 8 to 10 centimeters. So coming to the index case, it was a 16-year-old girl who presented with recurrent episode of cholangitis. Ultrasound and MRCP showed the gross fusiform dilatation of CSD and CBD with associated pancreatic biliary malunion. The RCP balloon sweep stone retrieval was already done in this patient. So we start the procedure with the H of falciform followed by the H of gallbladder. Then we proceed to the dissection, and then we doubly clip the cystic artery and divide it. As the patient had episode of cholangitis previously, there was some predominant peridorsal artery which was clipped and divided. Then we proceed to the medial dissection followed by lateral dissection. Then we gently move the posterior dissection and it will separate the cyst from the main portal vein and made up window posteriorly. After making the window, the cyst is being hitched with the Prolene suture and the intrapancreatic dissection is being continued. As the patient has a history of stent replacement, the stent is being removed. And at the tapered lower end of the cyst is being clipped and divided. Then we move to the callus dissection, the dissection from right hepatic artery. After that, we divide the cyst at the CSD and CBD junction. A thorough lavage is being given. We can see the CSD bifurcation. After that, the JJ is being done extracorporeally. Then we move to the J and the root limb is passed retrocollically. Then we start with the left side with first corner stitch. We usually use 5-0 polydapsonol. Then we do posterior layer in interrupted manner. This is the right corner stitch. Similarly, we do the anterior layer in the interrupted manner. This is the completed SJ. Then cholecystectomy is being done and a drain is being placed. So in the post-op protocol, we used to start clear liquid by day 1 and the full feed by day 4. For pain management, we use IV analgesia. Drain is removed by post-op day 3 or 4. In the follow-up, at first 3 months, we do LFT ultrasound and scintigraphy. Then for 2 years, 6 monthly, we do LFT ultrasound. Then the year after annually. So in last 2 years, 32 patients were operated with robotic hepatocytosis. Mean age of surgery was 6.5 years. Male to female ratio was 1:2.6. Mean weight at surgery was 22 kg. 20 patients presented with cholangitis and 12 with pancreatitis. In 5 patients, pre-operatively ERCP, stone removal and stenting was already done. As the variations are very common in biliary anatomy, we found it in 25% patients. 2 patients have ductal variation, anatomy variation, and 6 patients have arterial anatomy variation. Mean operating time was 376 minutes and mean consult time was 335 minutes. 4 patients have intraoperative complications. In one, we have hardware malfunction when we have tearing of CSD, and 2 patients have hemorrhage from aberrant cystic artery. 1 patient required blood transfusion. None patient required conversion to open or lap. 4 patients have post-operative complication. 1 had biliary leak. 3 had post-side infection. In 3 patients in late period, we found who have an anastomotic stricture, which was managed with ultrasound-guided dilatation. Mean
It's time, Anju. Can you please wrap
time to
up?
full feed was 96 hours. Mean hospital stay was 7.6. Our mean follow-up is 15 minutes. All patients are asymptomatic with normal LFT and satisfactory outcome. So, in the conclusion, robotic hepatocytostomy is feasible, safe, and effective treatment for choledochosis with minimal morbidity. And with reduction of cost and greater access to the robotic platform in future, it has potential to become the standard of care. Thank you.
Thank you, Dr. Anju. If the chairpersons have any questions for Anju?
May I just ask what is the normal incidence of pancreatitis post choledochal cyst excision? Because probably you quoted it is really high.
It was in a pre-surgery, 12 patients.
Okay. So thank you.
Thank you. Moving on to the next presentation. Anju, can you please stop your screen share?
Yes.
And may I request Shreya from BJ Wadia Hospital to start sharing her screen, please. Can somebody confirm that Shreya is on board and she's presenting? Yeah, okay.
Is it visible, ma'am?
Yes, please. You may start.
Good morning, everyone. I'm Dr. Shreya Tomar. I'll be presenting long-term outcomes of biliary atresia in a tertiary care center, retrospective data analysis of 8 years. Biliary atresia is a cholangiopathy with varied etiology. Kasai potoenterostomy is practiced by many surgeons as the initial line of management. The native liver survivors need a long-term follow-up. Our aim was to analyze retrospective data of patients from 2015 to 2022 in Bai-Jerbai Wadia Hospital for children. Age at surgery, bilirubin levels post-surgery, the CMV association, readmissions, cholangitis, portal hypertension, and death in patients with native liver were studied. There were a total of 127 patients, out of which 28 were lost to follow-up. Of the 99 patients, 47% are alive, of which 41% are alive with the native liver. The age at surgery was much more in the expired arm than that of the native liver survivors, the maximum being 210 days. 78% in the expired arm were CMV positive, in contrast to 22% in the native liver survivors. The bilirubin came down to less than 2 milligram per deciliter in the first 6 months in about 5 to 6% of expired arm, while it came down to 41% in the native liver survivors. There were 28 readmissions in 18 patients. 66% were due to cholangitis, totally amounting to less than 1 readmission per patient per year. 17 developed portal hypertension that was managed on medication. In the expired arm, 10 had associated cardiac anomalies. The deaths were due to liver failure in 78%, and maximum occurred within 1 year of surgery. 12 patients did not agree for liver transplant. There were 4 deaths among the 10 who underwent liver transplant. The average age of liver transplant was around 11 months. All had underwent liver transplant elsewhere, as it was not yet started in Wadia. The deaths occurred due to acute rejection and post-op complications. The deaths occurred within 1 month of transplant. It could possibly be due to evolving years of pediatric liver transplant. Nearly half of biliary atresia patients following Kasai's potoenterostomy survived beyond 10 years with their native liver. The American Biliary Registry of 100 institutions that included 670 children, the 5-year survival rate post-Kasai photoenterostomy was 46%. Similar results of survival with the native liver have been found in our study. 19 patients with more than 5-year follow-up are alive with a maximum age of 7.5 years. Charded et al. In 2000 studied data between 1986 to 1996, in which there were 440 patients of Kasai who were operated, out of which 60 patients were of more than 90 days. The 5-year overall survival was 55%, and success was achieved even at an age of 141 days. So age alone is not a contraindication for surgery, provided the liver status is preserved. These patients need a long-term follow-up for cholangitis, portal hypertension, and occasionally malignancy. Cholangitis occurs due to ascending infection from the bilioenteric anastomosis, and most occur within the first 2 years of surgery. In our study, cholangitis occurred in 43% of the patients that was managed on IV antibiotics. According to Shao et al., post-op cholangitis in a native liver, the survival decreases with each episode of cholangitis. Bu et al. In 125 patients of post-Kasai found 70% of the patients to have developed portal hypertension with a mean age of 13 months. In the Bicatry series, of the 44 patients of 63, in a long-term follow-up of more than 20 years, found that 70% had features of portal hypertension. In our study, there were 36% patients who developed portal hypertension either clinically or on ultrasound or on upper GI endoscopy, though a further long-term follow-up is required. The rates of readmissions for portal hypertension and cholangitis, as seen in our study, were similar to a study by Hakkinen et al. In 387 patients managed by King's College Hospital over 18 years, 5 patients developed hepatocellular carcinoma. No cases of malignancy were reported till date in our study, though a further long-term follow-up is required. CMV IgM positivity is associated with poor prognosis, as was seen in our study. In a review article in 2015 by Dr. Priya Ramchandran et al., stated that the only contraindication to Kasai photoenterostomy is advanced liver disease, that is uncorrectable coagulopathy and low albumin levels. A successful Kasai photoenterostomy can avoid transplant in up to 1/3 of children, thereby delaying the need for immunosuppression. Therefore, to conclude, nearly half of biliary atresia patients survive with native liver. The native liver survivors are at a risk of cholangitis and portal hypertension that can be treated with medication. But if repeated episodes occur, it becomes an indication for liver transplant. In centers where liver transplant is not available and wherever feasible, Kasai photoenterostomy should not be denied. These are my references. Thank you.
Thank you, Shreya. Do the chairpersons have any questions, Dr. Thikchen?
Yeah, it's very interesting that she gave in a lot of references, which I think took away a lot of her time. But what I would like to know is what is the purpose of this paper? Because we already know that biliary atresia should have treatment with a Kasai's first. So is there a reason why we need to put this forward again? Is it that liver transplant is occurring too many times in small children and we need to put this forward? That's the question I have.
Yes, ma'am. Thank you, ma'am. Primary liver transplant is being practiced in many patients, even in those where the liver status is preserved. So I just wanted to put my point forward that a Kasai photoenterostomy can be done in patients with a preserved liver status, even though the age is more. And if need be, later on, the child may undergo a liver transplant.
Very, very good. Very good. Thank you.
Thank you.
Thank you, Shreya. May I request the next presenter to please start their screen share? Your slides are visible, Dr. Meena. Can we go to the first slide, please?
So, very good morning to everyone. I'm Dr. Meena, working in PSG Hospital. So this is a paper which was published in the JIAPS in March 2022. So titled Pathology and Surgical Management of Urinary Retention After ARM Surgery.
Can you go full screen, please?
Please keep talking, Meena, because your timer is already on.
So, in coming to introduction, the neurogenic bladder manifests in around 30 to 50% of children with ARM. So we were looking at children who presented to us with urinary retention post-ARM surgery. So urinary retention can be due to various reasons in these children, like associated congenital anomalies or operative structural injury like a urethral injury, or post-operative neurovesical dysfunction due to damage to the nerves during surgery. So the aim of our study was to analyze the etiology, effects, management, and outcome of patients who presented with urinary retention with a history of undergoing pull-through operation for ARMs. It was done as a retrospective study. We had a total of 25 children who had been operated elsewhere for ARM and then presented to PSG with urinary problems. So out of the 25, the male to female ratio was 17:8. All the 8 girls had cloaca, and of the 14 males, of the 17 males, 14 were high, 2 intermediate, and 1 low. So the data we collected were the type of anorectal anomaly, the previous surgery which had been done, the symptomatology, presence of UTI, ultrasound, MCU images, and evaluation of spine by X-ray or MRI, renal function test, and further follow-up. So the results from the study were around 18 patients had a predominant neurogenic component, which was detected on an UDS or cystogram or scopy, where the bladder was trabeculated or they had a poorly compliant bladder on a UDS. And partial sacral agenesis was present in 16 patients. So during presentation itself, around 17 children of 25 had an abnormal EGFR with a renal failure. Around 8 of them had a EGFR between 90 to 60. 7 were between 59 and 30, and in 2 patients it was between 29 and 15. So the predominant component being neurogenic, the other component was the operative injury. So there were 3 complete urethral transections and 5 partial urethral injuries. All had been managed by SPC before they were sent to us. So this is a picture of a male who had a near total urethral transection, and another male with a complete total urethral transection and VUR, and a female with complete urethral transection and VUR. So another component which we saw was 3 of these children had a retained rectal stump, so which was causing bladder neck obstruction due to the compression. And this is a picture of a neurogenic bladder with bilateral VUR. Now coming to the management which was done in these children. So our first primary concern was in those children with urinary obstruction, it was to relieve the urinary obstruction. So they had been managed by vesicostomy earlier elsewhere, or if they came to us, they were managed with metrophenol after the child was stabilized. So the goals of management should be safe upper tracts first, and then to see whether we can provide a normal voiding per urethra, or whether the child needs a continent low pressure urinary reservoir with a metrophenol, or by doing a CIC per urethra. And in children with urethral transections, in all those children, initial diversion had been done, like I said, and then a permanent reconstruction was done. And in 17 of these children with neurogenic bladders, augmentation was done to protect the upper tracts. And out of the 27 refluxing units, 18 units were reimplanted. And bladder neck closure was done in 2 children, in 1 girl who had a single kidney and who had developed a vesicocutaneous fistula after urethral transection, and in another boy who had a damaged sphincter. So the outcome after our study was in all the 25 children, they showed recovery of renal function except for 2, and hydronephrosis had resolved in 10 and was stabilized in the others, and reflux had resolved in all the cases except in 1 we did not do an MCU. All the cases were socially continent. 10 cases are voiding normally. Out of them, 7 are doing nighttime drainage via the metrophenol as well, and 15 cases are on CIC. And no child remains incontinent, though the bladder neck surgery had been done in only 2 out of the 25 children. So discussion, so our main aim to assess these children should be before ARM surgery, we should have to look for subtle signs of neurogenic bladder and evaluate the spine as well. A proper lupogram is mandatory. And in children with cloaca with very total urethral mobilization causing problems, our dictum is always do an anorectal pull through first, and probably a vaginoplasty can be done later at a prepubertal age. And surgical expertise is another concern. And catheter has to be kept before surgery, and we should make sure not to encircle the fistula. And if the urethra is injured, then suprapubic diversion should be done initially, and probably reconstruction can be planned 3 years later. So follow-up in all cases of ARM post-surgery should be done with a proper history and examination for urinary symptoms and evaluation whenever necessary. So to conclude, final reconstruction requires consideration of urethral reconstruction, a need for Mitrofenov, and to look for the need for anti-reflux surgery, and then the fourth one, whether augmentation is necessary. So our goal of renal preservation, social continence, and normal voiding in the selected cases has been achieved. Thank you.
Thank you, Meena. Very nice paper. I just have a couple of questions here. One is, what was the age at which the PSRP or whatever was done in children who had urethral injury? That's number one. And the second is, was there a male without partial sacral agenesis and no urethral injury or retained pouch? So except for these three, was there any male who actually had a neurogenic bladder, or was a partial sacral agenesis the hallmark of neurogenic bladder in your group of patients?
Okay, out of these 25, 12 boys had a neurogenic component. Out of them, 5 had a partial urethral injury, whereas all the other 7 had a neurogenic bladder as such.
No, because of partial sacral agenesis or with a normal sacrum?
No, with a normal sacrum. I mean, but a few out of them, 16 had partial sacral agenesis. But I think out of the 12 boys who had...
Out of 18 boys,
no,
how many of them had a normal sacrum with neurogenic bladder?
Around 7 had a normal sacrum. So out of that, 5 had a partial urethral injury, but with no sacral agenesis.
Okay.
Right. Thank you, Dr. Meena. May we move on to the last presentation of this session by Dr. Gayatri from Vijayawada Hospital.
Good morning, everybody. And this is not a typical paper. This actually describes our journey of starting a transplant program in the public children's hospital. In the last atresia paper, somebody had asked question as to where in Mumbai is the liver transplant done, and somebody has answered also that many places. Yes, it is available at many places, but till recently it was a privilege of the rich community and out of scope of the poor children. And this is an endeavor of the Bai Hospital to start a dedicated pediatric solid organ transplant program in the for the underprivileged children. So this journey actually is stemmed from the realization that there is a huge gap between the demand and supply of the organs. The NATO database states that there are nearly 5 lakh Indians die every year due to unavailability of organs like kidney and liver. So there is a huge gap, and despite being the second largest population in the world, we are not able to increase our organ donation rate. The cadaver donations also need to improve. So this has improved only marginally as compared to the 2013 and 2014 data. The organ donation awareness has to be increased,
just see that there is like so many people who are waiting for an organ transplant. There was 90,000 children waiting for an organ transplant. Whenever this cadaveric organ is available, it is the adults who get the priority over the children. So a dedicated pediatric surgery solid organ transplant unit is the need of the hour. And in keeping this in mind, we had started this program of the currently we are doing the kidney transplant, liver transplant, and we also have a tissue bank. This actually required a huge collaboration between so many multiple departments. The nephrology, the gastroenterology, the supportive departments like microbiology, laboratory, critical care, nursing staff, etc., etc. To achieve this purpose, we had the international and national collaborations. Also, we had an official tie-up with Birmingham Children's Hospital, the KEM Hospital, the Apollo Hospital, and the Medicover Hospital. So it was necessary to get all these people work towards one goal and be unified in their approach and the aim. Apart from the transplantation program, spreading awareness regarding this program and spreading awareness regarding organ donation was also necessary, and therefore we had conducted so many activities in order to spread this awareness. This is the photograph of the marathon that was conducted. And also because we are a public hospital, we need to have a lot of fundraising activities in order to raise the funds for poor children so that they can afford the transplant. So this is the various trusts that help us in this endeavor. So this is to summarize the milestones that we have achieved as the transplant program. Although the numbers are not so impressive, but then this program is in its infancy and we are progressing slowly but surely. So to summarize, we have had 4 liver transplants, 3 living related but deceased donors, 7 kidney transplant, out of which 2 were deceased donor. We also have had cadaveric multi-organ donation. As far as donation is concerned, the children being the donor are very, very less in number, and it requires a huge courage and compassion on the part of the parents to consent to the cadaveric donation when children are concerned. We also had tissue donation, and we also had our retrieval team going and retrieving the organs for the transplant. So after the 2 cadaveric donation, this was the youngest one, and this child was also the youngest in the city to be donating the organs. This child had a traumatic brain injury and brain death, and the parents had shown exemplary courage, compassion in order to donate the organ. This was a very, very heartwarming moment when we all gave the honor walk and salute to this little donor. So this was the youngest donor in the city, and we had like a lot of appreciation for the family. Apart from that, we also engaged in yes, brainstem death workshop is the awareness of the classes were conducted so that everybody is aware of what is the brainstem death and what is the procedure for declaring the brainstem death. We also have this parent support group for transplant patients, both renal and as well as kidney, wherein the parents they interact with each other, both the transplanted and on the waiting list, so that whatever their misconceptions or their doubts, they clear it with the faculty and also with each other. They share their experiences and they also support each other emotionally. We had also had in the last organ donation day, the entire hospital has pledged for organ donation, all the doctors and the staff nurses together. So looking at future, we are now looking at starting a cardiac transplant unit We are also trying to do the faculty training for all the various transplants that we have in offering. We are also trying to improve the awareness program, and in future we want to have a dedicated transplant infrastructure. Apart from that, we also plan to appeal to government bodies for insurance scheme for underprivileged children, so that more and more children can afford this, can benefit from this program. Thank you.
Hello. If there's no one else, can I ask the question?
Yes,
Yes,
please,
yes.
Dr. Dixit.
Okay, this is a very difficult topic. But I would like to put a spin on the pediatric surgical aspect of it. How many pediatric surgeons are actually involved in the transplant procedures, liver or renal?
Very few, and that is why we are this endeavor is to start a dedicated pediatric solid transplant unit. All over the world, it is the adult surgeons who are doing the transplants in pediatric people. And as we all know that small child is not a miniature adult. As pediatric surgeons, we know the difference, how the adult surgeons handle the tissues and how we handle the tissues. And therefore, it is an appeal to all the pediatric surgeons, especially the younger lot, to take interest and progress in this direction.
Okay, thank you.
Thank you.
Wonderful attempt, Dr. Gayatri. With this, we come to the end of the first free paper session. If I may have last wrapping up words by any of the chairpersons, please. Dr. Lakshmi.
All three of us.
Sorry. Yes, please.
We'll go by whoever is.
Dr. Tishan, we can start with you, please.
Okay, for me, I think I would like to laud everybody for, waking up early and joining this group and presenting all that they did. And while I really don't believe, because we have too much competition in the world anyways, but this marking that is there, I guess that is part of what everybody wants to get done. I, however, would like to say that everybody who participated or will participate today, you're already a winner. And the fact that you've come to a forum where women are doing this primarily to support each other, that I think is the best trophy that you can get. Okay, thank you.
Wonderful. Thank you very much. Dr. Mamta, do you wish to say any final words?
I agree with Dr. Tishan, and all presentations were wonderful, and marks are, I think, only factor was the exceeding time limit. Otherwise, all papers were wonderful and did justice for their presentations.
Sure. Dr. Lakshmi?
I have nothing new to add. Nice session. We should move on because we're very late.
Sure. Thank you, everyone. So we move on to the next session, which is surgical videos. So most of the videos are being presented by consultants, so I'm hoping that they shall keep that in time. To chair the sessions, may I please invite Dr. Satyashri, Dr. Sunita, and Dr. Poonam, please. I hope our chairpersons are there online.
Yeah, good morning. Am I audible?
You're audible, ma'am. Good morning.
Good morning, Virendra. How are you?
Very well, ma'am. Thank you. So with your permission, can we start with the first presentation by Dr. Charu?
Yeah, absolutely.
Thank you.
A warm welcome to everyone. Good morning, everyone. Dr. Sunita and Dr. Poonam, I hope you're on board. And special request to the speakers, since we are already way ahead of the time that we are supposed to keep, stick to your videos, please. 5 minutes presentation with clarity and 1 minute for question and answer.
Dr. Charu, are you there?
Yes, ma'am. Good morning, ma'am. I'm here. I'm just sharing.
Sure, and just a gentle reminder that this session will not be marked because most of the presentations are by consultants.
Okay.
Sure, thank you. Your screen is visible. Yes, please start.
A very good morning to all. With greetings from IAPS Raipur, I'm Dr. Charu Tiwari. Assistant Professor in Pediatric Surgery, and I shall be presenting an operative video on distal pancreatectomy for solid and pseudopapillary epithelial neoplasm that is spent in a child. The pancreatic SPEN is the epithelial tumor of low malignant potential and accounts for 1% to 2% of all exocrine pancreatic tumors. Young females in second to third decades are most commonly affected. This is rare in children. I present a 10-year-old girl with pain abdomen with no clinical abdominal finding. Sonography, CECT abdomen, and FDG PET-CT suggested a SPEN of size 3.9 into 3.5 into 1.5 centimeter. Blood investigations were normal except for raised serum CA19-9 level that was also borderline raised. These are the CT images. This is the solid pseudo and it is solid and cystic area, the tumor. There was no evidence of metastasis, so we planned spleen preserving distal pancreatectomy. Abdomen transfer sensation. The operative video follows. Transverse upper abdominal incision, peritoneum open, gastrocolic ligament being divided, the pancreas being exposed. The inferior border of pancreas was then dissected to expose the superior mesenteric vein. This is the superior mesenteric vein. This is the tumor in the body of pancreas. This is the neck of pancreas. A tunnel is being created between the superior mesenteric vein and the posterior surface of neck of pancreas. The tunnel is being created. Vessel loop is being passed through it. Roller gauze makes the tunnel even wider, little bit more dissection to allow for passing the stapler. Line of division is being marked, endo-GI stapler being applied. So it is being fired, thereby completing the division. The division is completed. Now the distal pancreas along with the tumor is then gently divided and separated all around. First superiorly, ligating all the branches from the splenic artery and vein, preserving the splenic vein because we don't want to do splenectomy. Posterior dissection and inferior dissection using bipolar and harmonic. Some vessels we are having divided in ligatures, the harmonic. The dissection continues. We'll just skip it. The last part. Pancreatectomy is completed. On the cut edge of the pancreatic head, the stippled edge, fibrin glue is being applied. Post-operative recovery was uneventful. The histopathology confirmed the diagnosis. Raw specimen was 5.5 into 3 into 3.2 centimeter. Tumor size was 3.2 into 2.5 into 1.5 centimeter, heterogeneous, admixture of solid and pseudopapillary areas. The infiltrating cells, these are the malignant cells with the uniform cells and uniform nuclei, fine chromatic, and no atypical mitotic figures, lymph nodes negative, margins negative. The girl is asymptomatic at 3 months follow-up. Thank you.
Thank you, Charu, for an excellent presentation and very well made video. Dr. Sunita and Dr. Poonam, any questions from your side? Dr. Sunita and Dr. Poonam?
Nice. Hello, everyone. Am I audible? Am I audible?
Yes, yes.
Yes, ma'am.
So, any specific reason, Dr. Charu, you use endo GI stapler instead of other linear cutter staplers for this? The space is limitation or what?
There's a small jaws. No? It will be very easy to go through the small tunnel. And
space
it was a
constraints.
triple part. Yes, space.
Yes. Okay.
Thank you, ma'am.
Rare tumor
Yes, ma'am.
skill displayed.
Yeah, and since it has been non-metastatic, there is no adhesions, predominantly benign. I think the plane between the SMV and the pancreas could be easily gone into, isn't it, Charu?
Yes, ma'am. Yes, ma'am. It was easy to dissect also. It was easy to create planes. It was easy to preserve the vessels also. Otherwise, we would have needed to be splenic vein if had been sacrificed, then we have to do splenectomy also.
Absolutely.
There was no adhesions, nothing, no metastasis, no contamination. Everything was fine.
Well done.
Thank you, ma'am.
The next, yeah. So the next presentation would be by Dr. Lakshmi. Can I invite?
Yeah. Can everybody hear me? I'll start my video. So this is about thoracoscopic lung preserving resection of interlobar sequestration. So it's a 7-year-old boy with an antenatally diagnosed lesion. You can see quite small, involving the left lower lobe with a feeding vessel and 3 episodes of chest infections. So we had a bronchial blocker for single lung ventilation, lateral decubitus, surgeon and assistant standing in the front of the patient. And we had 3 ports, and we approached, first of all, the feeding vessels at the junction between the diaphragm and the mediastinum. So some adhesions were there from the previous surgery, which we had from the previous infections, which needed to be released. We also divided part of the inferior pulmonary ligament, which we used harmonic for this. I would have liked to use ligature, but I think that day we didn't have that, so we had to use the harmonic. So here we are releasing some of the adhesions and then approaching the feeding vessels, which are coming from the abdominal aorta. Many times these feeding vessels are not a single vessel, but multiple vessels, and these are all arteries. The venous drainage of the interlobar sequestration goes in through the lung parenchyma, so it will be only arteries coming from here. So here in this situation, we had 3 vessels. 2 of them were small, which we were able to clip, but one of them probably also had some lung tissue around it and was quite bulky. So you can see what we do for that. So these are polymer clips. And it's important to see that at thoracoscopy, we had this great view of the feeding vessels, and we are able to have a good seal and good control of the vessels with relative ease. So the second vessel, we have just used some harmonic to burn up the tissue proximally. Yeah. So this last tissue was quite bulky and a clip wouldn't go across. So we decided to suture ligate it with vicryl suture. So that's a 3O vicryl we have used. in an intracorporeal knot for that. So we have ligated on both sides, and when you use harmonic on top of that, which generally people advise us not to do, you can see that the ligature at the side of the lung actually comes off. So again, that's a lesson for us to learn. Once we've ligated securely, we should just cut it rather than using a harmonic or any kind of energy device. So then this was a sequestration involving the posterior basal segment. So we needed to go posteriorly on the lung. So we needed an extra port and an instrument to help retract the lung appropriately so that we would be able to excise the lesion accurately. So we've got a fourth retractor, which is pulling the lobe down and then giving us access to the posterior aspect of the, pulling the lung down and giving us access to the posterior aspect. You can see the junction between the abnormal lung tissue and the normal tissue very clearly in this. So here again, we're using the harmonic to go correctly at that junction. So thereby we are able to preserve most of that normal left lower lobe lung and just take out the lesion per se. So lung preserving surgery is particularly useful when there are multiple lobes involved and also when there are small lesions where we don't have to sacrifice too much of normal lung tissue. We may have some areas of small air leaks, and that needs to be tackled at the end of after the resection. So that's our full resection. The specimen will be retrieved at the end. So we leave that to one side. Now, because it is that the patient is having a bronchial blocker, we don't see the huge areas of air leak right now, and that will have to be checked at the end of the procedure. We are putting multiple interrupted vital sutures to close the raw area on the lung, thereby, because most of these air leaks will be parenchymal air leaks. Once you close the lung over like this, the air leaks will stop. So the specimen was retrieved at the end, and we checked for the air leak after removing the bronchial blocker, and we were able to discharge the patient on day 3. Thank you.
Thank you, Lakshmi ma'am. That was a wonderful presentation. Now, I have a couple of questions for you, ma'am. One is regarding the bronchial blockers. What do you use for a bronchial blocker, and who does it in your institute? You do it yourself, or do you take the help of the pulmonology, pediatric pulmonology? How is it?
No, our anesthetists are very skilled in this, and because it is a smaller child, we were not able to use a double lumen tube. We used a bronchial blocker, and it's entirely done by them. I really don't know how they do it. In an older child, we have access to a double lumen tube also, which they will insert for us, and that's even better because we can actually inflate the lung in between the procedure, check for air leaks, and then deflate the lung and do all kinds of things. So bronchial blocker, we've got to do that in the end.
Yes. The second thing, ma'am, that you said, once it is ligated, that is, we do an actual ligation with the thread, whatever it is. We are not supposed to use any harmonic. That is what you said. I think that's a very good takeaway message from this, whatever you have told us, because the ligatures will then slip away. Now, coming to the third one, when it is an artery, vein, and bronchus, how do you go about ligating? Which one first? Can you tell for the youngsters?
See, that difference only comes when we are doing a lobectomy and we are going through the fissure. So in that sort of situation, then we would always try to do the arteries first and then go for the veins so that we don't have a lot of blood pooling in the lung parenchyma. And then the bronchus will be done last. If you're going to go for a lobectomy, the important point to note is we should not make the bronchus bare for a long distance because the bronchus blood supply is very tenuous. So if you bare the area of bronchus for a considerable distance before you ligate it or transfix or whatever you want to do, then you're more likely to have a blowout from the bronchus and an air leak. So the advantage of doing a parenchymal resection is that we don't actually approach the bronchus at all. Intralobar sequestrations don't have a feeding bronchus or a bronchiole, and it's only aerated from the pores of Kohn through the adjacent lung. So it's much simpler than going for a total lobectomy, and it's quite unnecessary in small lesions. That's what I want to say.
Thank you, ma'am. Dr. Sunita, Dr. Poonam?
No, ma'am, you asked my questions. I want to know about the bronchial blockers. So that's fine. Nice presentation, ma'am. We learned and
I
we
think they
are still
use
in the
something like
learning.
it's like a Fogarty that they put into the bronchus. So that's what I think they do. And they've got to position it carefully because it is done in the supine position. And then the patient has to be turned to the side to a thoracotomy position. And then they recheck that the bronchial blocker is working.
Okay.
Thank you, ma'am. Thank you.
The next presentation is by Dr. Shalini Sinha. May I request you to share your slides, Dr. Shalini?
Yeah, thank you so much. Just a minute, I'm just sharing my. Are you able to see my screen?
Yes, ma'am.
And is the audio also there?
Yeah, it was starting to run. Yeah.
Really a very good opportunity today. I'm just presenting a short video on gross total excision of L2 neuroblastoma in a 4-year-old child. The high-risk neuroblastoma had a very large tumor to begin with, encasing the aorta and inferior mesenteric artery. And this is after the rapid Kojek, it has shrunk, but still there was a 4 by 3 centimeter mass completely encasing the inferior mesenteric artery. So on table, actually, you could feel the hard calcified mass. And I usually use a chevron incision. May look very large, but that's how it is for neuroblastoma. Like any other routine procedure, and use all the energy devices that you can. Usually monopolar, bipolar, and harmonic are good enough. It's important, especially for the youngsters, that first thing we need to do is to visualize the aorta. The IVC. This is the aorta, and it is bifurcated. You see the ureter over there. So very important to delineate the aorta and also the distal inferior mesenteric artery. And of course, we won't start dividing the tumor till we get the origin of the inferior mesenteric artery from the aorta. And that's what I'm dissecting over here. You have to be very patient and just go slowly, get your hemostasis. Dissect it. Aortic bifurcation. And this is the aorta, IVC. Connecting the two. Laterally, the mesenteric vessel. The aorta, aortic bifurcation. This is our tumor, and this is probably the origin of inferior mesenteric. So yeah, I've got the mesenteric artery exiting here. I've got the inferior mesenteric taped distal to the tumor, and now I'm going to tape it at the origin. So this dissection just has to be patient and slow and careful, that's all. It's possible, although it looks a little tricky in the beginning. So here I've got it taped. And if the planes are correct, then usually there's not much blood loss. Once in a while, I do get a lot of blood loss also. So then I'm just bisecting the tumor. So as we all know, for neuroblastoma, piecemeal removal is completely acceptable. And as long as we can remove about 95% of the tumor, there is gross total excision. That is, the outcomes are same. And because it's a high-risk neuroblastoma, this child will go for autologous stem cell transplant. So we need to do the cytoreductive surgery as much as possible. So using a blade, we can do the subintimal dissection. And as you can see, slowly the entire inferior mesenteric artery is now coming out clearly. Ongoing hemostasis.
I think we lost Dr. Shalini.
Dr. Poonam, are you able to see Dr. Shalini's video or is it frozen?
I'm really
No,
sorry. I think
no.
my
Oh.
computer just crashed. I don't know what happened. Halfway through.
We should have it on our drive, isn't it? Otherwise, we can share
Yes,
from
it is
there.
there. It is there. It's just the last 2 minutes are left. If somebody can share, I'm here through my phone. I don't know what happened. Suddenly it just blanked out.
Otherwise, I think you can just describe verbally. We've seen quite a lot of the video. Yeah.
Yeah. I can share the video on the group also. So I was almost there. The vessel was delineated, and then we just cut the tumor into 2 pieces or 3 pieces, depending on whatever is the situation, and then remove it piecemeal. And at the end, I just spray some fibrin sealant glue, just like in the previous video they had shown. This child went on to have a chyle leak later on, and also had an adhesive intestinal obstruction. The duration of the surgery was about 7 hours, and blood loss about 50 ml. We were able to extubate the child at the end of the surgery. And subsequently, he underwent autologous stem cell transplant and has been followed up for about 1.5 years. And so far, fingers crossed, is doing well. Thank you so much. So just a small message for the youngsters, doing surgery for L2 neuroblastoma, especially when it's encasing aorta and it's major vessels, you should not undertake it maybe right in the beginning of your career, just get some help. But again, if you're just slow, patient, it's not very difficult at all. You just need some patience. That's it. Thank you.
Thank you, Shalini. That was once again a very, very wonderfully demonstrated video and presentation. I think, like you said, the takeaway message to the youngsters is to be patient and to lose that fear of, that something might bleed and we are dissecting close to the aorta. Maybe with experience, all of them will learn. That's very important. Lovely. And do post the video for us. We would love to see it till the end. Thank you.
I'll post it in the group right away.
Absolutely. Sunita, Poonam?
No questions, ma'am. It was a wonderful demonstration. Please post, ma'am, video.
Excellent dissection. The importance is of isolating the vessel proximal and distal to the tumor, both having control and then then dividing the tumor. It was really nice.
Yes, absolutely. And also always need to arrange a good amount of blood in case there is bleeding. And, you need to coordinate with your anesthetist. If the VMA is high, you need to block them, give them alpha block at 5 days and get everything under control. And a good PICU team, that is also very important.
Can I ask a question? Did you have a backup in case it was not possible to save the artery? A Gore-Tex patch or something? Any backup?
Yeah, we do have a backup, but I mean, fortunately or whatever, I've never had to do that. The more tricky ones are, I haven't edited my videos, the more tricky ones are when it's encasing the renal vessels. So trying to save the kidney and especially vein. I feel artery is easier to work because it's thick walled, you can see it, it's pulsating, you can feel it. A vein, when it's encasing the IVC or the renal vein, it becomes a little tricky sometimes. And one of the first few cases that I did, maybe I lost the kidney later on. And although I preserved the vein, but later on the kidney just became atrophic. Touch wood, and thankfully, after that, I've never had this problem. I think it just needs some experience.
Wonderful. Thank you, Dr. Shalini. We move on to the last presentation by Dr. Pawai. Are you online, madam, Dr. Pawai?
Hello.
Yes, ma'am.
Yeah. What's happening? I think it's Ovia's presentation. Ovia, are you there? Okay, go on to the next presentation. I'll find out what's happening. Okay. Hello,
Okay.
Linda. Yeah.
Yes,
This is
ma'am.
the
Yes.
last presentation, I think.
I just checked what's happening to her. Okay.
Okay. Okay, fine, ma'am. So maybe we can, Dr. Manjusha, can we come back to Dr. Pawai after a while and we'll move on to the next
Yes.
free paper? Yeah.
Huh.
All right. All right. I thank all the chairpersons. Dr. Satashri, would you want to extend an invitation for the upcoming IAPS-CON and take this opportunity and platform to everyone?
Absolutely. I was wanting to do that, Virender. I hope I'm not boring everybody with my messages, but then it's a sincere request. Please, all of you are most welcome to join us in IAPS-CON 2024. Once again, share your wonderful platform of celebrating women's progress in pediatric surgery. And we look forward to you. And please do come. I mean, that's all I can say. And support us and make it a grand success.
Wish you all the best for all the preparations, ma'am. Thank you, Sunita and Dr. Poonam. Any last wrap-up words that you have for all the women presenters?
Actually, I am also from the UP.
Sorry,
So
Sunita.
I
Dr. Pawai was wanting to
Yeah,
say
I'm
something.
ready.
Sorry.
Yeah.
Sure, ma'am. Can you please?
Sorry,
Yeah, sure.
I'm ready. You want me to start?
Yes, please, ma'am. Can you share your slides?
Okay, sure.
Please? Yeah.
Yes, please.
Sorry, Sunita. We'll come back to you. Hold that.
Sorry.
The slide is
This is just
visible,
a
ma'am.
robo-assisted, robo-assisted lab pull through for a high anorectal anomaly. And as you can see, this was a high anomaly, which was done and a lupogram followed, which showed it was adequate colon was there, and there was a rectourethral fistula. So we proceeded with a robotic anorectal robo-assisted anorectal pull through. This was the rectoprosthetic urethral fistula as sagittal view. And the steps of surgery are division of the peritoneal deflection, identification of the fistula, dissection where it narrows down, where it enters the urinary tract, division of the fistula, mobilization of the bowel, and anoplasty. And this is my video. Yeah. As you can see, it was just a 5 kg child, and I used a penetrating bipolar and a hook on my right, division of the fistula, peritoneal deflection. You can see the ureter and the vas deferens. 3 ports. One is a camera port, 2 ports for my arms, and 1 assistant port who will be doing the suction, retracting the bowel, etc. I usually do it lab, but we have procured a robo, and what I found was the magnification, the wrist movements made my job much easier. As you can see, the retrorectal dissection is complete. I did have a urethral catheter in the bladder. What was wonderful is I could see each muscle fiber and divide it. And then as it narrowed down, then a submucosal dissection was started. Occasionally, you will have to take a stay suture in the bladder. The hook dissection is something which we usually do it laparoscopically, so it makes us very comfortable. There was a little stool, and my assistant just helped me suction it out. You can see the vision is excellent. After that, I apply a clip to the proximal end so that there's no spillage. The distal end is usually left open. And once that is done, you can see the levator. Actually, we used a muscle stimulator from below, and we could actually position it exactly in the center. What I'm holding with my left hand is the fistula, which was not ligated. Then what is very wonderful is once you take out the trocar also, the pole still remains. So you go exactly in the same plane which you created the first time. Serial dilatation is done. And depending on the size of the baby, we decide which trocar should go in, either a 10 or a 12. And then it is pulled down, taking care that there's no twist in the mesentery. And in case if the bowel is not adequate, then mobilization can be done from above, and if necessary, even near the colostomy. And this was another case, and you can see the discrepancy in the size and the fistula dissection before ligation. And we usually put it in a lithotomy position. We can sit behind, in front of the robo and do a plastic comfortably. And this is the post-operative result. So an abdominal approach is indicated in high anorectal anomaly. Doing a proper lipogram before surgery shows you the anatomy before planning your surgery. The magnification, precision, because of the robotic platform, helps in safe dissection, placement of the bowel in the center of the muscles with minimal damage to the surrounding structures. All patients operated by this technique are doing well, but the time period is less to compare with open bar lap to state the long-term outcome and advantage. Thank you.
Thank you, Pavai Madam. Excellent, encouraging video for all the youngsters out here. Dr. Satyashri, do you have any questions for Madam Pavai?
Yeah, definitely. Pavai ma'am, it was beautifully, very, very, very clear and very well shown to us. And more, we are also here switching over from PSA-RP to LARP now. And we are getting excellent results too, like you have shown us. What do you, once again, like I always talk, the youngsters are all with us, the trainees are with us. Do you think that they should first learn now PSA-RP, ASA-RP, because it was the golden stone at one point of time, and subsequently switch on to LARP? Or what is your take on this now?
No, I am very clear. We need to be good in open surgery. We have to know how to do a PSA-RP, ASA-RP with minimal complications. And you do an abdominal approach only when indicated. What I wanted to show the youngsters was, I am very new to this field, and I haven't done too many cases, but I'm able to do a variety of cases because I am trained in open surgery, in lap surgery, and now in robotic surgery. Robotic surgery, the learning curve is very, very less, and with a good mentor, somebody, especially an adult who's just standing beside you, they don't know all this anatomy. But just in case if you have any issues, to guide you has really helped me. And I'm able to do even a lap. We did a pancreatic jejunostomy and Sandeep was there. So it is excellent. All of us should learn. It's a part of our surgical armamentarium. And I do not call myself as a robotic surgeon. I use robotics when necessary, so that it's a part, just like a stethoscope is part of a physician, robotic is a part of the thing. That's what I want to tell the juniors. Thank you.
There is one question in the chat box. Someone has asked, what is the youngest age for which the robotic surgery can be attempted?
I think once you have crossed your learning curve, I know that Shripati even does it for a 3 kg child. So I have, for the anorectals, I've kept it as a 4.5 kg. For the pyeloplasties, my incision is very small. So for the smaller babies, I usually do it only open. Only for the older children, I do a robotic pyeloplasty.
Thank you, Pavai ma'am. Sunita, Poonam?
Ma'am, do you leave the distal fistula always open, or there are some indications when you suture it also?
Poonam, our dictum has been, we go as close as possible. As you see, you can narrow it down where it is narrowing. Your lupogram also tells you all this. And we go, even in open, even in lab, we have never ligated it. So that's the same principle which I've been following. I do keep a catheter for 48 to 72 hours, and we have not had any issue.
And ma'am, which robot you have, means?
Da
Which
Vinci X.
Da
Da
Vinci.
Vinci X. Yes, it's 1.5 years since we got that. So what I want all of you to realize is once it is bought, make it a rule that we as pediatric surgeons should be trained. So anything in robotic, they don't start without calling me. Okay, so take the lead. That's all I'm like ma'am was telling, renal transplant, cardiac transplant. Okay, so it is ours. Anyone less than 18 years is ours.
Anyone from India is using the Indian robot, or what is their experience? Is I read last time in a WhatsApp group, so I am become interested about that. What is Indian version? How much cost? Yes.
Actually, I had been to the robotic conference which was held by ARIS on Friday and Saturday. Came back just this morning for this conference. The SSI is coming in a big way. The cost is good, and we have to start thinking made in India. So I'm sure another 2-3 years it will be at least come close to Da Vinci.
Thank you, ma'am. Thank you, ma'am.
Robotic surgery training actually is a very important thing nowadays, because many of the robotics making surgery easier as compared to laparoscopy is one thing, but most of the parents are also demanding robotic surgery nowadays. So it's very important to be trained in robotic surgery along with the open and the laparoscopic skills.
What I have seen and what I shared with CMC also, the thing is, even the third day in a lap pancreatic vaginotomy, we are up and about. It can never happen in the open. And in a lap, you can do it. But the strain on the surgeon for doing so much stitching is there. That's not there, even for a beginner like me. So.
Sure. Thank you, Dr. Pavahi. And as
Thank
Dr.
you.
Lakshmi pointed out, we are running almost half an hour behind schedule. So I thank the chairpersons and we move on to the next session. May I request my co-moderator, Dr. Rupa, to take it from here, please, for the next session.
Thank you. Thank you all.
Very good morning. I would request Dr. Joshna Kirtane ma'am, Dr. Archana Puri, and Dr. Shosmita Bhatnagar to please take over the free paper session 2. Okay, and I hope the presenters are ready. Our first presenter is Dr. Sunita Singh. Are you presenting this or your resident? Dr. Sunita Singh, are you presenting this paper?
Yes, ma'am. I am sharing my screen.
Okay. We'll start then. I hope all the chairpersons are here.
Can you see the screen, ma'am?
Okay. Yes.
Yes.
No, we cannot see your
Good
screen
morning.
yet. We cannot
Yes.
see your screen. Please share again, or just wait for 2 seconds.
It's not visible, ma'am?
The screen is not visible. Your photograph is visible.
Okay, ma'am. Is it visible now?
Yeah, it's just started. Please wait. Yeah, it's visible. Please start.
Okay, ma'am. So, good morning, all. I wish to discuss a spectrum of antenatally suspected congenital anomalies and their postnatal management at a multidisciplinary clinic. The data is from the 2 centers, that is AIMS Raipur and AIMS Raebareli, where I was working for about 8 years. So, as we know that proper counseling for a malformed fetus need adequate information regarding the type of malformation, its prognosis, availability of surgical treatments, and its outcome. So, in the team of counselors, pediatric surgeons play a very important role. So, we are enclosed in this multidisciplinary clinic at both the previous and the current working institute, and the aim of my study is to study the demography respect the surgical outcome in pregnancy suspected of structural birth defects. So the data of OPD records for last 10 years is analyze, and these are our some management algorithm in the antenatal period for various diseases and for the postnatal period. So we have 450 cases of referred cases of complicated pregnancy having the suspected congenital anomalies, of which this 269 anomalies are counseled by us also only, and 155 were referred to the other centers. Because they really need the genetic testing and the further workups. We have very less number of 26 cases of minor anomalies, because these are anomalies mostly tackled by the obstetrician itself. So their number is little less in this series. After counseling, 157 pregnancy lost the follow-up, 18 were advised for the termination, and 35 were delivered. 25 were underwent surgery, and 5 died after birth, and all these cases are the cases of congenital diaphragmatic hernia, and further many took LAMA and didn't underwent further surgery in postnatal period. So most of the women were the unbooked, uneducated, and the lower socioeconomic status, mostly spontaneously conceived. 33% were the age more than 33 years, and the primary graveyard. There is no history of radiation exposure or the fever with rash or exposure of teratogenic drugs in any of them. And surprisingly, the none of taking preconceptional folic acid that is recommended by the even the Indian government by at various levels of maternal care. Instead, they are taking the multivitamins. Exact incidence for chromosomal anomalies I could not comment. This table is based on the data on the literature, because most of these cases refer to other center for further workup. Out of the MTP cases, these are our the indications for the advising for the MTP. And for other anomalies, craniospinal and the cardiovascular anomalies were the most common one. These are the cases in the post-delivery period which either undergo surgery in the follow-up or they are managed conservatively. And these 25 patients were underwent surgery in the postnatal period, out of which 18 was discharged successfully. So to enhance my skills for counseling, I did a course in the genetic counseling at SGPGI that is near my center. So based on that training, I wish to discuss a case with you, all people, that how we can also apply our basic knowledge or some software application in the counseling of these patients. This is a case of duodenal suspected double bubble sign, that is duodenal atresia, diagnosed in the antenatal period and referred to our clinic at 28 weeks of gestation. And he has the another signs of single umbilical artery, double bubble sign, right axis deviation of the heart, and with the mid-facial hypoplasia. So we take the history, and in the history we saw that only one similar baby in the family is affected in the maternal uncle side in the paternal group. So this is a Phenomizer is a software that is freely available in the web, and we can put our such items that these terms are called HBO terms. So we put all the 4 HBO term, that is the duodenal atresia with abnormalities of the face, then single umbilical artery, and then the abnormal heart morphology in this software. So we come with the uh, diagnosis of 2 possible diagnosis, that is the charge association and the Town-Broke syndromes. Once this this is the format of the report, we came out with this software. And then OMIM is again a free available online software where we can search further search in detail about this baby. So based on this all report, we came to we suspected that our child may be a case of the charge syndromes, and we were able to concern that many cases are the sporadic. However, it is recently said that charges association is not association but is a syndrome, because the gene CDS7 has been identified for it. But with the literature, we were eager to look other features of anomalies in our child in the antenatal period also. We can direct the obstetrician radiologist to specifically look for these features. These red ones are the features that we can see in our child. All this is a software based uh, information. Then this CDH7 gene can be detected again in the gene review process, where we can know how to this gene can be detected, and based on that we advise for microarray test in this baby. And there is the SGPGI is a well-known center for this facility. But this child come to be no clinically significant copy number variation in this child. So we were now sure that this is not a charge association, so we can counsel patient. The other possibility again, Town-Brockie syndrome is again discussed, and in the similar feature there are various feature that we can morphologically identify this child. Unfortunately, this baby died in intrauterine period at 34 weeks of gestation, and when the delivery was performed, we were again called to look for the possible cause of the demise in this baby. And then at our center, we did the autopsy of this child, where all the features of ultrasound was confirmed, but no additional information was achieved in the autopsy. So this is a new skill that I'm trying to learn to counsel my patient, so that proper care can be given to this patient. Thank you.
Hello, am I audible?
Yes, ma'am.
Thank you, Sunita, for presenting a very large database of antenatally detected anomalies. I have got two questions for you. Based on your vast experience, who are the subset of pediatric surgical patients, or who are the babies in whom you would recommend such a detailed genetic workup? One. And secondly, in genitourinary